I want to present a traumatic cataract which is 42 years old with inferior zonular lysis. Visual acuity is 0.3. The patient was never operated before. There is no vitreous prolapse visible now. I inject an air bubble and then vision blue to stain the interior capsule. This might not be necessary, but I want to perform a stable and good rhexis. And you actually never regret staining the interior capsule. The patient is today 72 years old and had this trauma on his eye for a long time ago and was referred to us now for a cataract surgery. The main problem in this eye is, of course, the inferior zonular lysis. It is advisable to implant a capsular tension ring. The zonules seem to be quite stable at the superior part of the eye. And the whole lens is a bit subluxated upwards. Hydrodissection. The next step is the implantation of a capsular tension ring in order to stabilize the inferior capsule. Now comes the capsular tension ring. It's very important that the first part of the ring is inside the capsular bag. Now we come to the end of the ring, and you see that the end of the ring is located in the interior chamber and not inside the capsular bag. It needs to be placed properly with help of a manipulator. Now it is properly placed inside the capsular bag, and we can continue with phacoemulsification. This is an uneventful phacoemulsification. Of course, you have to work very atraumatic in order not to make the zonular lysis worse. You want to preserve the capsular bag and you want to implant the IOL inside the capsular bag. That's why it is important to operate with as little stress on the zonules as possible. You can see now the capsular tension ring inferiorly. I'm not able to extract the other half of the nucleus. I therefore inject viscoelastics and inflate the capsular bag, and then I luxate the lens fragments into the interior chamber. Now they are very easy to remove with the phaco hand piece. So again, use all kind of maneuvers in order to ensure a atraumatic phacoemulsification surgery. The big advantage of a capsular tension ring inside the bag now is that it holds the lens capsule away from the phaco handpiece when performing these maneuvers. So you can aspirate the epinucleus without having the fear that you also aspirate the lens capsule. This is especially the case in the inferior part of the lens capsule. So you're actually quite safe now when aspirating fragments. But one part of the surgery is more difficult with capsular tension ring, and that is irrigation and aspiration, which comes next. This part is easy to remove. But you see now that the cortex is difficult to remove because the capsular tension ring presses against the cortex. So I'm now first removing the cortex which is fastened to the posterior capsule in order to reduce the trauma when pulling at the cortex, because of if you pull very much on the cortex, you induce again stress on the zonules, and you will possibly lose the capsular bag. So again, it's important to perform the irrigation aspiration part as atraumatic as possible. You see how difficult it is to remove the cortex, because the capsular tension ring holds the cortex back. If you have problems at 12 o'clock, please don't continue. Perform a paracentesis at 6 o'clock and then aspirate the cortex from 6 o'clock. Some cortex is left. You see again how tricky it is to remove the cortex because of the capsular tension ring. The final step is the implantation of the IOL. I use a simple one-piece IOL. Some residual cortex can be easily removed now under irrigation aspiration. The lens is well centrated. There's a little bit of pressure against the lens inferiorly. I therefore inject an air bubble to stabilize the interior chamber. Thank you very much.